So I'm going to kick off really by just setting the scene of where we are within the UK and what we've done in terms of a trialist network and what that might bring to us over and above the question relating to the trial and the agent that we're studying. So I'm not talking about the results of the BOXIT study, more about what these types of trials bring to us in terms of a UK structure and the data streams that come through. So the BOXIT was a randomised placebo-controlled trial. It commenced in 2007. It was completely recruited by 2012, and we had a data freeze in 2014. It was funded by Cancer Research UK. It was coordinated through the ICR and sponsored by the ICR and UCL, and it used what we now know to be the NCRI, the National Cancer Research Institute Network. So the National Cancer Research Institute was something that came after the NHS plan. What is it? Well, it's a body of clinical studies groups. We have them in prostate, bladder, kidney and testes. And these are a connection of researchers, clinicians, statisticians, trial managers that coordinate and help promote studies that come through onto what is called the national portfolio. I think we'll hear more about the NCRI as we go through the week, but Pivotal is a network, an infrastructure of hospitals that recruit and support trials activity. We know that these are effective. We have the EORTC, well established, very effective, but hugely expensive. And prior to that, we had the Medical Research Council, which brought us the neoadjuvant study, the study of adjuvant mitomycin post-resection, and the study of radiotherapy versus BCG for T1G3 disease. So we have a track record, we have a European body, and now we have this UK infrastructure of hospitals, and these are the active hospitals across the UK that are recruiting to trials. Now, what do trials tell us? Well, they give us an insight into contemporary management, and this is patient data that is linked from baseline through to follow-up. In the BOXIT study, we have 472 patients recruited. It's the largest study to be performed in non-muscle invasive bladder cancer in the UK. 347 are high risk, only 13 lost to follow-up. The median overall follow-up at this point in time is 39 months, but out to 60 months. That gives us a lot of information because we collect data on tumour size, multiplicity, smoking history, prior recurrence rate, and we lose very little data. So for example, for smoking, you won't see this, but I think we're missing data for smoking history on maybe 10 patients. We're missing data on prior recurrence history on 5 patients. So it's a phenomenal data set. How can we put it to good use? Well, I mentioned we're going to hear about the bladder cancer diagnosis and management guidelines. We're going to hear a counter and a contrast about the European guidelines. And how can trials like BOXIT help? Well, both guidelines give us what they are, indications of how we should conduct best practice. For example, we have in NICE, you can take intermediate risk disease and survey at 3, 9 and 18 months, and once a year thereafter, potentially with a view to discharge. We can ask the question of BOXIT data. This is a very interesting slide from BOXIT which shows the recurrence-free survival. This is intermediate risk disease, and this is high-risk disease. And we can look at this data and say, is that a sensible thing to do? Is it too much surveillance? Is it too little surveillance? The other thing that this highlights, this Kaplan-Meier, is that the recurrence-free survival for patients with intermediate risk disease is lower than the recurrence-free survival for patients with high-risk disease. Why might that be? Well, Hugh Mosterfit has done some work on BOXIT, and this is some interesting data. These are the patients who received or should have received mitomycin-1 post-resection. Patients in blue received mitomycin-1, patients in red did not receive it. 44 cases in a trial setting in which it was recommended did not receive mitomycin-1 post-resection. 35% of patients did not receive 6 installations of mitomycin C for intermediate risk disease. So BOXIT gives us a very interesting insight into our contemporary practice. Are we doing as well as we think we're doing? And clearly that would be up for debate. But this could be the reason why we see a reduction in recurrence in intermediate risk disease that is not as high as we would expect. And perhaps the intermediate risk are a bit of a lost cohort. So it's a rich theme for data, but where are we going? Well, we've increased the centres. Many of these centres are now running additional trials. We have the HIM study reporting today, the Calibre trial open, the HIVEC trial open, and the PHOTO trial open, and a rich pipeline coming through. One of the things that we continue to learn is about data and the need for evidence. So this is some data that we'll extrapolate from HIM, but these are studies in which post-BCG there has been some work done. None of them are randomised. Even valrubicin, which is FDA approved, was not randomised to placebo. There's everything from interferon to gemcitabine, and none of it really is that evidence-based. I'll take the example of valrubicin. Valrubicin, this is the data that got valrubicin its FDA approved license. It was non-randomised to placebo. It was randomised against 2 different regimes, and the disease-free survival rate post-BCG at 1 year was 10%. This is the control arm of the HIM study, exactly the same patient cohort. It's more contemporary management, but in a control where there is institutional standard, the disease-free survival at 1 year is 54.8%. Same populations, no control arm, no real strong evidence despite getting FDA approved. So we'll continue to pull out some very interesting data. The other thing we're moving forward with is our interactions with industry, and industry are at a standoff position. They don't have access to any of the data, but we work with Prostrakin, Synergo, Combat and Physion, and what we now see are these new technology industries coming in and offering us some very interesting ways to challenge what we're doing and develop new strategies. We also have these clinical trials units, very expert in conducting and performing trials, and any of us can go forward now with an idea, take it to this clinical studies group and start to develop a concept into trial. So it's an evolving network, the NCRI. We can now challenge new concepts, validate technologies, look at the new emerging therapeutics coming in, such as the PD-L1 inhibitors. The concept of a trial for every patient is probably equivalent to all of us just raising the bar. I'll finish with this slide. I hope you're sitting there and you see your hospital on it, because if you do, you're working with an engaged team that are multidisciplinary, working right through from the different aspects and teams within your urology department. But it's a sterling job. It is support that is much valued and will make a difference to how we manage our patients and how we change our management of patients and challenge our guidelines. So well done, everybody.